So there are also closed captions that are being automatically generated. So you can press the CC button at the bottom of your screen if you want to access those. So my name is Sarah Bourdin, and I am delighted to welcome you all to the first webinar in MeSH's webinar series. It's called Strengthening Routine HIV Data, a Female Researcher's Perspective. So it's the name of the webinar series. And the aim of the series is sort of to discover the perspective and work of brilliant women in the HIV field. And so these women will discuss their contributions to strengthening the understanding, collection, analysis, and use of routine HIV data towards the aim of accelerating and tracking HIV decline in sub-Saharan Africa. So yeah, please make sure to follow us on Twitter and the website for updates on the series. My colleague Tom will just pop those in the chat box if you want to follow the links. And yeah, without, it gives me great pleasure to introduce Parinita, Bhattacharjee, and Dr. Marissa Becker from the University of Manitoba, who are going to launch us off with this great first webinar. So without any further ado, I'm going to hand it over to you both, and you can start if you'd like.
Thanks very much, Sarah, and good afternoon, good morning, and good evening to everyone. I'm going to start us off, and then I will pass it over to Parinita to take us through the rest of the presentation. Parinita and I are really happy to be here to present on behalf of the entire transitions team, which is an amazing multidisciplinary team of researchers from Canada, the US, Kenya, Ukraine, India, and in the UK. Next slide, please.
Oh, there we go.
Perfect, excellent, thank you. So the objective of this study, which we refer to as the transition study, is shown in the schematic here. And the idea of transitions, or the objectives as we talked about in the study, was to characterize HIV risk faced by young women during two important periods of time: the transition period, which was the time that we have spoken about from first sex until self-declared entry into sex work, and then the access gap during the first 2 years of formal sex work, but prior to program engagement. And to understand how, if we were able to reach adolescent girls and young women during these periods of time, how that might mitigate the HIV epidemics. Next slide, please. So the idea to try to understand these two periods of time came from work that we were doing at the time in South India as a part of the Bill and Melinda Gates funded Avahan initiative for HIV prevention for key populations. And our program partners were sharing some of the challenges that they had faced in reaching young women who sell sex. And at the same time, we were seeing high rates of HIV infection among young and new female sex workers. Oops, sorry, I hope you can see that okay. I'm just gonna, okay, there we go. And this wasn't unique to India. Colleagues across other contexts were seeing similar issues. And so we hypothesized, as shown here in this slide, that the risk of HIV and the vulnerabilities were high, or highest actually, during these periods of time. And just to note that although this cartoon really sort of depicts this as sort of a line, we recognize that these were not sort of linear or sequential events, and fully appreciate the fluidity and dynamic nature of these early periods or during these early sexual life courses of adolescent girls and young women. Next slide, please. This slide depicts the study design for transitions, and we began with a process of geographic mapping and enumeration of adolescent girls and young women and young women who sell sex. And we mapped out, following sort of a process that we've done within programs and for other research studies, we mapped out the locations where female sex workers and other adolescent girls and young women would congregate. And then that formed the sampling frame for the study. And we then implemented a cross-sectional biobehavioral survey amongst adolescent girls and young women who were 14 to 24 years of age. And we had two study sites, which I'll talk about in a minute, and had a sample size of about 1,800 participants per study site. And we implemented a structured survey along with biological component where we did rapid HIV testing. And then that sort of formed our data set for all of the analysis, including mathematical modeling. Next slide, please. So we had, as I noted, 2 study settings that we implemented the study in. For the purpose of today and for this webinar, we're just going to be showing results from the Kenya site. But we wanted to have sort of different, both sociocultural as well as epidemiologic contexts in which to work. So the study was implemented in Mombasa, Kenya, which I'll talk a bit more about in terms of the context. And as well as Dnipro, Ukraine, which is an industrial city in eastern Ukraine. It's about 200 kilometers west of Donetsk, which is currently sort of the center of the conflict zone. Both sites have a population of about 1 million people overall. Next slide, please. So Mombasa, for those that are less familiar, is a beautiful coastal city in southeast Kenya. It's a very large port center and has a big tourism industry. And the HIV prevalence in Mombasa County itself is about 5.6% as compared to the national HIV prevalence of Kenya, which is just less than 5%. Next slide, please. There are an estimated close to 11,000 female sex workers in Mombasa. And among sex workers, about 16% reported to be living with HIV, as compared to a general prevalence among women of 6.6%. And female sex workers in Mombasa practice sex work across a range of different locations. And those locations, as I noted in the study design slide, form the basis for where we recruited participants from for this study. Next slide, please. So I'm going to jump into some of the findings from transitions, and then I'm going to pass it over to Parinita, who's going to talk about some of the programmatic interventions for young female sex workers. So the next few slides come from a paper that's shown here in the top left corner of the screen. And what we did is we wanted to try to understand some of the vulnerabilities faced by adolescent girls and young women at their very sort of first sex event. So really early on in that sort of schematic that I showed earlier. And for the purposes of the study for analysis, we had 3 groups that we talked about for some of the analyses, and each group went through sort of a different series of questions, depending on how they responded to a few questions that started off the interview. And so we had, as you'll see here in this slide, we had adolescent girls and young women who self-identified as engaging in sex work. We also had a group of women who identified engaging in transactional sex, but who didn't identify as formal sex workers or who didn't indicate that they had sold sex. And then we had a group of women who, adolescent girls and young women, who didn't indicate that they had engaged in transactional sex or sex work, but that they were engaging in casual sex. And so overall, as I noted at the start, our sample size was about 1,800. And we had 700 and have to go back to remember 715 women in the casual sex group, 177 women who identified as engaging in transactional sex, and 408 women who self-identified as sex workers from the Mombasa site. And so you'll see the 3 columns shown here. And at the time of survey, the median age of respondents was about 19 years. And the median age at first sex was 16 years, with just slightly lower age at first sex amongst female sex workers or young women who sold sex of about 15.5 years. And what you'll see is, as shown here in this slide, that 23 up to 35% of participants indicated that their first sex event took place before the age of 15. And 30 up to just over 50% of participants indicated that that first sex event was within that first year of menarche. Next slide, please. And so we also looked at sort of a range of events or exposures or experiences from that first sex, including intergenerational sex, as shown on that first row here, which ranged from just under 4% up to 13%. Amongst individuals in our study, 40 to almost 60% of adolescent girls and young women indicated that at that first sex event, there was an exchange of something, gifts or money or other resources. And amongst those that did, 16 to just over 30% indicated that there was an exchange of money at that first sex event. For a large proportion of participants, that event had been arranged by someone other than themselves. Next slide, please. And when we looked at the experiences of that first event, 36 up to just under 50% of participants in the study indicated that that first sex event was coerced. And up to 15% of adolescent girls and young women indicated that their first sex event was a forced first sex event. And so what we saw from this analysis was that many of these experiences at that very early sexual experience were shared across this range of adolescent girls and young women who participated in the study. But some of these vulnerabilities seem to certainly be higher amongst young women who identified as selling sex or identified as sex workers. Next slide, please. We also looked at experiences and reports around reproductive health. And here, this slide and the next slide come from an analysis led by Andrea Wilson from our team. And in this slide, she's compared those young women who engaged in casual or transactional sex with those who identified as sex workers. And what you'll see is that over half of women who identified as sex workers had indicated that they had been pregnant at some point. And just under 30% of other participants in the study had also had a pregnancy by 19. Remember, the median age in the study was about 19 years, so by 19 years of age. Amongst those who had been pregnant, about a quarter had had an abortion. And contraception use was reported as not being used by just under 18% of women who identified as engaging in sex work, and over 30% of those who identified as engaging in transactional or casual sex. And the methods of birth control or contraception are shown here. Next slide, please. So as mentioned earlier, at that very first sex event, a significant proportion had experienced coercion or a forced sex event. And Parinita and Mike Pickles from UK had looked further into the experiences of gender-based violence. And this is a table drawn from that analysis. And what you see is that about 30% of young women who sold sex identified as having experienced either physical or sexual violence. And amongst the other participants in this study, experiences of violence, both physical and sexual violence, were around 20 up to 28% for them as well. Police violence was quite common amongst young women who sold sex, with over 30% having experienced police violence in the year prior to the study. Next slide, please. So just a few more slides from me, and then I will pass it back to Parinita to talk about some of the interventions. So as I had mentioned at the start, one of the early objectives of this study was really to try to understand that transition period, as we referred to it. So again, that's a time from first sex to self-identification as a sex worker for those young women who indicated that they had identified as engaging in selling sex. And we had asked about that period of time where there was that self-identification in a range of different ways. But overall, what we saw is that formal sex work took place about 2 years after the first sex event. Next slide, please. And we also wanted to look again at that process or that period of time around program access or that access gap. And what we saw in the study was that very few of the participants and very few of the young women who sold sex were aware of programs that were available for female sex workers for HIV prevention. So only a quarter reported being aware of the program. And we created a cascade to be able to sort of understand access, and awareness to access and service use. And what we saw is that amongst those that were aware, only a quarter, were aware of programs, but only 15% of individuals had been contacted by a program. And then it drops off after that, with only 9% of young women who sold sex having used clinic services or used drop-in centers. Next slide, please. And we looked further to see whether that changed by age. So what you'll see is that, again, overall program access was quite low, but amongst those very young, the youngest of the young women who sold sex, the proportion that were aware of programs and that access services was even lower at 17%. Of 14 to 18-year-old women who identified, girls who identified as selling sex, aware of programs, and only 9% had been contacted by programs, with only 3% then using clinic services. Next slide, please. And Kenya, as we noted at the start, has an HIV prevalence amongst women of about 6%. And what we see here in our study was that the HIV prevalence amongst all participants was about 5.5%. And amongst those young women who identified as engaging in sex work, it was almost 10%. With those who engaged in transactional sex or reported engaging in casual sex at 3.3% and 3.7% respectively. And on the right side of this slide, what you see is that even amongst those very young participants, 14 to 18 years, the HIV prevalence was already 5.7%. So really suggesting high risk and high rates of infection very early on amongst this group of adolescent girls and young women. Next slide. So I'll just summarize some of the findings. Again, what we saw was that there were a number of significant and early vulnerabilities amongst these adolescent girls and young women who were congregating in these hotspots or locations, what we typically think about as being locations where female sex workers would gather to solicit clients. We saw high rates of pregnancy and high abortion amongst adolescent girls and young women, even higher amongst the young women who sold sex. High experiences of violence, both physical and sexual, and high police violence, particularly amongst young women who sold sex, with 34% having experienced violence in the last year. The transition period, so that time from first sex to when someone self-identified as a sex worker, was about 2 years. And interestingly, in Ukraine, what we saw was that the transition period was actually quite similar in terms of duration, as well as in terms of experiences of some of these vulnerabilities. There was significant program access gap, with 84% of young female sex workers in Kenya who had never had contact with a local program, and high early HIV prevalence amongst the population that participated in our study. So with that, I will pass it back to Parinita, and thank you all again for the opportunity to be here and to be sharing some of our results from this study. Pari, over to you.
Thank you, Marissa. Thanks, Laura. Sarah, next slide, please. Yeah, so I'm going to talk a little bit about the pilot intervention that we did with young female sex workers, learning and from the evidence that the transition project gave us. Next, please. So the transition data that Marissa shared was used to advocate with the Ministry of Health in Kenya to prioritize young female sex workers in the national key populations response. It was very useful that the transition data was collected in partnership with the National AIDS STI Control Project within the Ministry of Health. So the advocacy was so much easier, and NASCOP then led the development of a guidance to scale up implementation of HIV prevention programs with young key populations, which included young female sex workers. And then we initiated, in partnership with NASCOP and others, a pilot project in Mombasa, Kenya, to test if some of the interventions that are stated in the guidelines, are they feasible, and are they, would they have any impact or not? Next slide, please. So we designed a pilot project in partnership with ICRH, which is a civil society organization implementing female sex work intervention in Mombasa, and with Jalinde, University of Manitoba, PhD, and NASCOP. So as a consortium, we started this pilot project. So the pilot project was embedded within the larger female sex worker program, HIV interventions and HIV prevention and treatment program for female sex workers, which was being implemented by ICRH in Mombasa. Mombasa has around 6 counties, and ICRH is implementing the female sex worker prevention and treatment program in all the 6 counties, reaching around 7,000 female sex workers. So the pilot project with the younger female sex workers was in one of the sub-county called Kisauni. It was implemented in 12 wards of Kisauni, covering 104 hotspot. And as Marissa said, hotspot is a site where a sex worker meets a client or has sex. Kisauni as a sub-county was selected because during the mapping exercise, we estimated a higher number of young female sex workers in Kisauni County. So the project engaged 10 young female sex workers. Young female sex workers for the project was defined as 15 to 24-year-old. And that's how it is also defined in the guidelines. So we engaged 10 young female sex worker peer educators, specifically to target the young sex workers, in addition to around 61 female sex workers that ICRH already had to reach around 7,000 adult sex workers in the project. Kisauni has 1 drop-in center and a clinic, which provides HIV prevention and treatment services to all sex workers. So the young sex workers were also linked to that drop-in center and service and clinic, and the clinic has around 2 clinicians. At the start of the project, when we looked at the data, ICRH had already registered around 750 young female sex workers between the age of 15 and 24. Around 10% of those registered 750 young sex workers were below 19 years, and 90% were above 19 years. The implementation time period was October 2019 to September 2020. And a point to note was that Kenya experienced COVID-19 in March 2020. And so 6 months of the project period was within the COVID-19 pandemic period, where it was the initial period, so there was lockdown, curfew, and all kinds of restrictions that happened. So we have to look at the evidence that is generated through this project with that lens in mind. Thank you. Next slide, please. So the package of intervention that was provided to the young sex workers included a comprehensive package of interventions, which included a structural, biomedical, and behavioral interventions. In the context of behavioral interventions, we had peer education, identification of young sex workers in the hotspots and their work site, micro-planning by peer educators to identify risk and vulnerability, and providing services based on risk and vulnerability of the young sex workers. There was condom distribution, including demonstration and referral to the project clinic for clinical services, including quarterly checkups. In the biomedical interventions, the project provided HIV testing. There was contraception and SRH services provided, risk assessment, and then provision of PrEP. Condoms and lubricants were provided also. There was also counseling that was done, risk reduction counseling that was done, and psychosocial support, STI screening, diagnosis and treatment, and The clinic also provided ART to people, sex workers who were living with HIV. In the context of structural interventions, there was information about rights that was provided to the young sex workers, but there was also post-violence support that was provided, psychosocial support, legal support, and other medical support. Linkage to vocational training institutions were created, and also linkage to educational scholarship for young sex workers who wanted to pursue further education. There was also sensitization of police and other power structures, and then sensitization of the county officials because we were working with under 18 girls. The expected outcomes are these, and I'll talk about it a little bit when we're talking about findings. Next slide, please. So we use kind of 3 data sources to measure change within the project in the period of 12 months. So the first data source was monthly program monitoring data. We had monthly data that would come in, aggregate data that would come in from the project. So we have 12 months data. Polling booth survey, this was a survey, population-based survey, which was conducted in the beginning of the project and then in the end of the project around October and November. And then there was in-depth interviews and focus group discussions with project staff and the young sex workers. 2 rounds of were done, once in the beginning of the project and one in the end. Next slide, please. In terms of findings, we found that there was increased identification, registration, and clinical visits. The monitoring data clearly showed that cumulative registration had increased, and not only had it increased for young sex workers above 20 years, but also below 20 years. So in the beginning of the project, we had 750 women who were registered. By 12 months, end of 12 months, we had around 1,376 young sex workers who were registered. Our polling booth data in the end, in the second round, November 2020, that was conducted, also showed that there was an increase in women visiting the clinic or the drop-in center in the last 3 months. In the qualitative findings, the outreach worker talked about how young KP program, we are supposed to recruit not supposed to recruit somebody from home, but we are only supposed to recruit somebody from the hotspot. So it was made very clear that we are not going to people's houses and identifying sex workers, but only if the women are coming to hotspots like bars or lodges, and they self-identify as sex worker, only they were recruited into the program. Next slide, please. There was also very clear indication that knowledge of HIV prevention and treatment increased. We had at least 2 knowledge questions in the polling booth survey, knowledge about condom use as a prevention tool, and knowledge about ARVs, especially looking at treatment as prevention, and seemed like by second round that information, more women had knowledge about prevention and treatment. And one of the young sex workers in the focus group discussion talked about, before I came here, I didn't know anything about health, about condom, about PrEP. But since I came to know about PrEP, or when someone rapes you out there, you can get help. But it also shows rape is quite common. Next slide, please. Interestingly, we did not find any difference in condom use. We asked several questions in relation to condom use. I have only shared one here in the polling booth survey, and we didn't find any change in condom use at last sex with paying client or with lovers and other condom use indicators. However, we did see that there was increase of use of PrEP. And for prevention, as ever, use of PrEP increase, but also current use of PrEP increase. And it could be also because intervention did take place during the COVID period, where there was a challenge with condom distribution and condom access. But we need to explore that a little bit more. Or it could be also possible that sex workers felt PrEP was a better way of protecting themselves in an environment where during COVID, where the violence was also very high and with less access. One of the peer educators, young peer educators, talked about, I get family planning for free, I get treated for STI for free, I take PrEP for free, I get tested for free, for HIV for free, I get free makeup, so I will be saving. So when I come to the drop-in center, I also take a bath for free. And to note that in Mombasa, there's shortage of water, you have to buy water to even take baths. So in the drop-in center, when a shower facility was provided, the young sex workers were very happy. Next slide, please. We did find that there was increased HIV testing and improved linkage to treatment. The monitoring data showed that out of around 1,376 women, young sex workers who were registered, 1,195 had tested for HIV with a positivity of 2.2%, 26 turned positive. 33% of active female sex workers were tested for the first time in the project. So there were also new testing that happened. The monitoring data also shows, it's because it was a pilot project and there was very close monitoring, that all those who were tested positive in the clinic were also enrolled in ART. It also helps that the clinic not only provides HIV testing, but also provides ART, so linkage becomes so much easier. The polling booth data did show that there was a bit of increase in people ever taking HIV tests, though there was not and no change in people taking tests in the last 3 months. That's a recent test. Next slide, please. There was, in the context of structural interventions, we did focus on stigma reduction and violence reduction and support. And we did find actually that to some extent, harassment and stigma may have increased. It could be because of sex work, it could be COVID times made it either difficult to hide that they were doing sex work, or they may have to do more sex work to earn money because other options were not there. But we do find that harassment or beaten up because of doing sex work by members of your family in the last 3 months increased. More people reported, and more people also reported discrimination in the educational institute. We found that there was no really change in experiencing support at the time of experiencing violence, harassment, or discrimination in the last 3 months. Next slide, please. The respondents also reported increase in dependency in sex work, and again, it has to be explored a little bit more, but the reports also say that, or the anecdotal data also say that the women, because there were no other sources of really income, and because during the COVID period, there was lockdown, there was curfew, women had to actually do more sex work to take care of their day-to-day living expenses. One of the community mobilizers also said that the families allege that we are spoiling young girls, giving them condoms, FP services, and PrEP. They believe that girls have not started sex work and are very innocent. They are virgins, even though we found most of those girls in the hotspot. But this also talks about, I think, the quote talks about engagement of family and other stakeholders that becomes very necessary when we are working with young sex workers. Next slide, please. So some things that really worked very well for the project, that was the peer outreach and education process, which provided support for the young sex workers. The drop-in center that provided multiple services under one roof was a very trusted and a safe space considered by the young sex workers, and it also provided non-judgmental service providers providing services. The project also involved young sex workers in planning and implementation. So there was a sense of ownership and there was a sense of accountability towards the project. The social connection with other female sex workers that the project provided through events and meetings worked quite well. and had positive response from the young sex workers, and support to address some of the non-HIV needs like economic support was also appreciated. And the elements of the program, that project that needed improvement was that young sex workers are very mobile, and that made sometimes follow-up challenging. So the project would have to think about how do we track them across different hotspots, different sub-counties. The legal framework in the country is not very supportive of providing sexual and reproductive health services to AGYW below 18 years, including family planning services. So though there were young girls who came for contraception services, there was a case when implant was put on a young girl who was below 18. Her grandmother came the next day, and actually she complained to the police that this was coerced by the project, and so it became a big issue. And because the police knew about the project, it was still okay, but the implant had to be taken out. And 3 months later, the same girl came to the clinic and she was pregnant. So she came to the clinic for the services for pregnant women. So FSWs are the young female sex workers are also not a homogeneous group and have diverse needs and priorities, and that needs to be understood. While some girls really liked the use of the drop-in center, some girls didn't want to come to the drop-in center because it was identified as a sex work related center. So they wanted to go to government facilities. So the project had to also build capacity and sensitize the government service providers. Continuous capacity building of implementing partners is important. It's not a one-time capacity building only. And then regular and multiple stakeholder engagement is critical. Sometimes when we are doing a female sex work program, we don't think about stakeholders beyond health or police, but in the context of young sex workers, we have to also involve families. We have to also involve the child rights groups, so the stakeholder engagement becomes broad and also becomes very, very critical. And of course, nobody was prepared for COVID and the kind of pandemic. So I think sometimes it's important that programs like this, it's not only to do with sex work, young sex workers, but programs with key populations do need to have some emergency preparedness solutions to address shocks that pandemics may cause. Though we found a lot of innovation from our sex work groups and key population groups to address, but the pandemic did shock us for almost 2 or 3 months, and the services were disrupted. Next slide, please. So just to conclude that, I think from Marissa and my presentation, I hope we have made this quite clear that young sex workers are an important part of the HIV epidemic, though they have been invisible and ignored in the sex work program or even AGYW program. They are ignored from both these programs and they're not really reached. Our work also provides evidence of the need to reach young female sex workers early enough and with also comprehensive programming. The intervention piece, we hope that showed that when supported by a strong policy guidance, embedding young female sex worker interventions within larger female sex work interventions is feasible and can be scaled up with, of course, few critical learnings. And so what we are doing right now is that lessons learned from this implementation is getting documented, and we are using these lessons to scale up a young sex work program in Kenya with support from Global Fund. I'll thank a lot of our partners in the next slide. Our partners, our donors, so many organizations and individuals have been involved in this process. I'd like to thank them, and I also like to thank London School, the MeSH group, for giving us an opportunity. Thank you.
Thank you both. That was really great. Let me just put the next slide. Yeah, thank you so much, and thank you for sharing the results from such an interesting study. I really love listening to what you're saying, and also, highlighting the importance of early HIV risk for epidemic control. So now we're going to pass on to the Q&A. So we want to make this as interactive as possible. So if you have any questions, please add them into the Q&A box. I know that some people have been doing it already. or alternatively, you can raise your hand and I'll give you the floor to ask your questions. But I just want to start off with a few questions that I have myself. So I wanted to know, so within like sort of the theme of this webinar, I just wanted to know in general, you as women, what were your experiences? What are your experiences within like the field of HIV and HIV research, and sort of what challenges you may have had, and what has being a woman helped at moments or not? Has this affected how you've collected data? You know, I just wanted to get your opinions on that.
Do you want to start, Parinita, or do you want me to? You're staying muted, so I'm assuming I'm starting. No problem. Yeah, thanks. So I just want to acknowledge that I think this theme for the webinar series is fantastic, and it's really nice to have a platform to talk about these this issue, Sarah. So thank you for facilitating that. I think it's great. You know, it's a big question, and it's a hard question to try to answer, but I can share a couple of my thoughts, and then would obviously welcome Parinita's thoughts as well. I think that I have been really fortunate to work with a remarkable group of women and to learn from a remarkable group of women, researchers, programmers, policymakers, and that's been, I think, so supportive to have that network around me as I've moved through sort of my life and my career as an HIV researcher and an HIV clinician. So when I don't have my research hat on, I have the opportunity and privilege of working as an HIV clinician. And so having that network and that support has been great. And I think it you know, it gives you a lens or perspective from which and in which to be able to approach the work that we do. There are challenges, of course. I have young children, and so the work-life balance is always an interesting one. But at the same time, I think I try to sort of see that as a way to present to my kids. I've got twin boys. Present to my kids sort of the work that I do and sort of the opportunities that I have. I think one of the things that I think I wish that I probably had more of earlier on, and even know probably now, is the having female role models or mentors, which I'm not sure that I had as much of early on. I had some and I clung to those. And so now what I try to do is to make sure that I provide that mentorship and support. And so I'm really lucky to be able to work with an amazing group of postdocs and graduate and undergraduate students, which I hope I can act as sort of a mentor to them. I'll stop and give Parinita a chance to jump in though.
Thanks, Marissa. Yeah, I mean, when I started, I live in Nairobi, Kenya now, but I started in India. I lived most of my life in India. I've studied in India. So as a young woman researcher, female researcher, I did find it quite challenging. It was very, very, the organizations that I have worked with were very, very male dominating. So I felt at a time, I had to shout more, I had to become louder, I had to become more, I have these more male characteristics just to kind of fit in or just to show that I'm there. And I also found that for a very long time, I also had I had less confidence in presenting myself or what I was doing because the male researchers around me, and I don't want to offend them, but would very openly and very boldly and very confidently share what they're doing, even if they're doing very less. They would be able to, I would call it brag very well, and I would feel, oh my God, my work is not very, very little in front of them, right? Much later in my life, I met a lot of women colleagues. I work with Marissa now, who's lovely. I've worked with other women researchers, and I think we have built a bond, and we kind of like working with each other because we think through things similarly. We have similar principles, but at the same time we kind of support each other. We build our confidence, and there is a lot of solidarity that comes along. right? So, and that's why I have a 15-year-old, and I'm trying to teach her now how to brag, be confident, be out there, and take your space, because sometimes nobody will give you that space unless you grab it in some ways. Don't be rude, don't be pushy, because these are the qualities that you don't like, but still be assertive and be there, and don't ever think that your ideas are little, your ideas are not important. I'll stop there as a woman researcher, very passionate though.
Thank you so much. Honestly, that was great, and it's good that women have role models such as yourselves for how to be within this field. And I completely understand a lot of what you were saying. So thank you for speaking up on it. So we have quite a few questions. So I think I'm not gonna ask the other ones that I had, and I'm gonna ask a few from the Q&A section. We're just having a look through now. So we've got one from Joanna Bussa, and they're asking if there are any legal barriers for organizations working with female sex workers to be able to explicitly target under 18-year-olds, because she's saying that that's an issue that they've been coming across in other settings. And I know you kind of mentioned this with the issue of like providing an implant to under 18-year-olds. So what have you sort of found any ways around that?
Yes, I think we were having challenges because under 18 is also trafficking, right? So if you bring them to a sex work clinic, and we may be accused of trafficking. And that's why we use the transition data to develop a policy first. So the government Ministry of Health already had a policy to provide HIV testing for 15-year and above. So that's why we used 15 as a cutoff point. We didn't have the courage to go below 15, but this is because Ministry of Health allows 15 years of girls 15 years and above to be tested, to provide HIV prevention services, and to do HIV research. That we developed this policy for 15 years and above. And this policy, we also very clearly said that we're not going to people's houses and finding 15-year-old and bringing them to a sex work clinic. We're going to be identifying young women who are in the hotspots, who are in the bars, who are in the lodges, and who self-identify themselves as sex workers. So this policy, supported by the Ministry of Health, provided us and the implementers confidence to implement HIV prevention program. But this policy is the HIV policy. It's still not family planning or our RSH policy, reproductive and sexual health policy. So family planning is still a very contentious issue in Kenya in the context of age, and that's where we had trouble with. But providing a condom, we didn't have so much of trouble with. So yeah, I think 2 or 3 things that we learned. Policy guidance is very important. Even if you have policy guidance, you have to spend a lot of time in building, doing stakeholder engagement, building confidence of all the stakeholders with the ministry, but also child welfare, the police, the families, in as collaborative way as possible to implement a program with sex workers, young sex workers. Not impossible, but you need the support structure.
Yeah, and great, thanks for that. And we have another question from, so we have a question from Brian Rice from MeSH, and he was asking, well, it's a bit of a long one, so I'll read it out. He was saying, in an analysis of adolescent girls who sell sex in Zimbabwe, we're currently exploring a pathway between poverty, an inability to pay school fees, early marriage, early entry into sex work, and a high risk of HIV and violence. With poverty and education being key, it was interesting to see some of your interventions. Are you able to accurately evaluate impact of your upstream interventions, is the question.
Brian, thanks so much. And I've read the paper from Zimbabwe, where they said they did work with the Dreams project, and that they did talk about how the girls did not really take up a lot of the upstream economic empowerment activities that was offered. I would say no, we have not been able to accurately measure, but we do think we are getting very positive signs that these kind of, young sex workers need options. And just the fact that you are not only talking about condoms, you're talking about violence prevention, you're talking about economic empowerment, you're talking about going back to school, just makes it very attractive for them to come and access services. They may not, I think out of the 1,300 women, we had around 25 girls who took scholarships. So it's a very, very small number, but the fact that we are offering it made it attractive. For their own life situations, it may not be possible for them to take up a skill building exercise or a scholarship at that point of time. But I think if this continues for a longer period of time, in your life cycle, you may have a phase where you want to go back to school and those options are available. But in terms of measurement, I don't think we could make very direct connection. Thanks.
Great, thank you for that. And it's so true that it's very important to have those options available if they would need them. So we've got a question from Eliza, and they're asking, they're saying, it is very interesting, the identification of the transition period. Do you know the lived experiences that lead women to start selling or exchanging sex?
Do you want me to go ahead, Parinita? Yeah, it's an excellent question, and transitions wasn't designed to try to answer those questions directly. We did do some work in India that looked at entry into sex work, and often for some women, certainly financial stresses and pressures were contributors to entry into sex work. In India, when we were doing the work, it was a slightly different context where we did the work, because there was also a long-standing tradition of entry into sex work from a cultural perspective in the certain area that we were working in. But in Kenya and Ukraine, where this study took place, transitions wasn't designed to really get at some of those drivers. One of the things that we've been interested in, and one of the things that has come out of transitions, is this recognition, as we showed in the presentation, about sort of these shared risks and vulnerabilities by many adolescent girls and young women for engaging both in formal sex work, but also other forms of sexual exchange, whether it's transactional sex or otherwise. And so Rob Lorway from our team sort of has termed this ecologies of risk. And what we're trying to do in follow-up is to really understand what it is about those overlapping social and structural sort of drivers and networks that might be influencing sort of how that local environment might sort of impact a young woman's sexual life course. And how adolescent girls and young women sort of relate to that environment. And so we're hoping to try to do some follow-up work to try to understand what it is exactly within those environments and within those ecologies that are really shaping or driving risk. And a part of that will be to try to understand sort of those experiences. But within transitions specifically, I don't have that data to be able to share at this point.
Great, thanks. I guess, well, I think we only have time for one last question. This is a bit of it's a bit outside, it's about COVID-19. But so this question is from Many Riziki Kislen, and they're wondering, well, Parinita's kind of typing the answer to that, but I think maybe you guys can just answer it quickly if you wanted live. But they're asking if do young sex workers screen for COVID-19 test before working? Yeah.
Thanks. I was just typing it, but it's easier to speak. No, no, not in Kenya. PCR test is expensive. So what the projects are doing instead, I wouldn't say instead, are doing is that, of course, providing information, sanitization, and all of that, but also encouraging the young sex workers to go for vaccination, because vaccination is now available in Kenya. But PCR tests are super expensive, so it will not be feasible for programs or projects to provide or even encourage the young sex workers to do that. Thanks.
Okay, great, thanks. I don't know what happened. I don't know if you can still see the slides. I feel like they've just left somehow. But I'm just going to stop screen sharing then. Thank you. I think so. That's all the time that we had for questions, sadly, but it was such an interesting presentation, and thank you so much to Parinita again and Marissa for joining us and for presenting. I hope you enjoyed this recording, and I hope all of you attendees enjoyed as well. So this was the first webinar in our series, and we've got another one coming in 3 weeks. So if you want to go to our website, again, the link for that is in the chat. And you can go on our website and see there'll be information just coming out now. And on the second webinar that we'll be having. And yeah, it'll be called Fixing the Leaks in the 95-95-95 Cascade, a case study for recent infection surveillance data use in Namibia, and presented by Nadeshi Conte and Susie Welty of the University of California. And it'll be 15th of September at the same time. Yeah, thank you. And also, sorry, the recording will be up of this presentation will be up on the website shortly. So you can have a look there, and yeah, you can interact with that there as well. So thank you again so much, and I hope you all have a good rest of your day. Thank you.
Thank you, Sarah. Bye.
Thanks very much. Bye, everyone.
Thanks, everyone. Goodbye.
Bye, Thomas.